Hey everyone, and welcome. If you're a nursing student or a practicing nurse, you are in the right place. Get ready for a Pharmacology Pop Quiz. We're going to put your clinical knowledge to the test with some rapid-fire questions and real-world scenarios. This is all about sharpening that critical thinking you need every single day. Let's get started. So, here's the game plan for our challenge. First, we'll cover the rules. They're simple, I promise. Then we'll jump into a rapid-fire review to get our brains warmed up. After that, we'll take what we know and apply it in some tricky patient scenarios, and we'll finish up with some critical can't-miss safety alerts. Sound good? Let's kick it off with the rules. Okay, the rules are super straightforward. I'll throw a question or a scenario your way. Go ahead and pause, think it through, come up with your best answer. Then we'll walk through the correct response together, and more importantly, the why behind it. The real goal here is to sharpen your clinical judgment. You ready for this? All right, it's time for round one, rapid fire. This round is all about speed and pulling up those fundamental pharmacology facts. You know, the stuff you absolutely have to know for any exam, and of course for safe practice. Here we go, first question coming at you.
You're going to see this medication pretty much everywhere. Your patient is on Lisinopril. I need two things from you. What class of drug is it, and what is that one classic telltale side effect you absolutely have to teach your patient about?
And there it is. Lisinopril is an angiotensin-converting enzyme inhibitor, or what we all call an ACE inhibitor. Now, it can cause other things like hypotension for sure, but the hallmark side effect, the one that always shows up on tests, is that annoying, dry, persistent cough. This happens because ACE inhibitors can cause a buildup of something called bradykinin in the lungs. It's that classic sign that might mean we need to switch our patient to a different class of drug, like an ARB.
Okay, next question. Picture this, a patient is actively wheezing, they're short of breath, and they reach for their albuterol inhaler. So, is this their everyday, take it on a schedule maintenance drug, or is this for emergencies?
Yes, you got it. It is a rescue inhaler, 100%. Albuterol is what we call a short-acting beta-2 agonist, or SABA. Its whole job is to work fast and open up the airways during an acute attack. It is not for daily prevention. All right, let's keep the momentum going. Next question.
Okay, Metformin. It's one of the most common oral antidiabetics out there. But there is a supercritical situation where you must hold this drug to prevent a really serious complication. Do you know when that is?
And here's the rule you can never forget. Metformin has to be held before any procedure that involves IV contrast dye. Here's why, and this is so important. Both the contrast dye and metformin are cleared by the kidneys. That dye can put some temporary stress on the kidneys, which could lead to a dangerous buildup of metformin in the body. That risks a severe, sometimes fatal condition called lactic acidosis. This is a non-negotiable safety rule.
Okay, the warm-up is officially over. Welcome to round two, the patient scenario challenge. We are moving way beyond simple recall now. It's time to look at the whole clinical picture, connect the dots, and figure out what the priority nursing action is.
All right, here's your first case. You've got a pregnant patient on an IV drip of magnesium sulfate to prevent seizures from preeclampsia. You walk into the room to do your assessment, and her respirations are slow, down to just 10 breaths a minute. And when you check her patellar reflex, you get nothing. It's absent. What is going on here?
The signs are all pointing to a pretty serious problem. Out of everything you could possibly do, what is the single most important first step, absolute priority action you need to take right now? Your first move, the most critical action, is to stop that infusion right now. That's the source of the whole problem. Your patient is showing classic signs of magnesium toxicity, respiratory depression, and loss of deep tendon reflexes. Your very next thought needs to be getting the antidote, which is calcium gluconate. And here's a pro tip. It should always be available right at the bedside anytime a patient is on a magnesium drip.
Okay, let's look at another super common scenario. You've got a 78-year-old patient on Warfarin for AFib. He tells you that he's noticed his stools are dark and kind of tarry. You pull up his latest labs and you see his INR is 4.5.
So, this situation is a bit complex. It requires more than just one action. What are two assessments you need to make immediately, and what is one absolutely crucial teaching point you need to reinforce with this patient?
Okay, first things first, that INR of 4.5 is way too high. The therapeutic range is usually 2 to 3. This tells you his blood is too thin, which confirms your suspicion of a GI bleed. Second, you have to do a full-body check for any other signs of bleeding, new bruises, blood in his urine, nosebleeds, you name it. And for teaching, the #1 rule with warfarin is consistency. Patients need to maintain a really steady intake of vitamin K from foods like leafy greens, because big swings in their diet can throw their INR all over the place.
All right, our final scenario takes us into oncology. Your patient is getting the chemotherapy drug Vincristine. They mentioned 2 new symptoms, a really bad numbness and tingling in their fingers, and they're also really struggling with constipation.
So these side effects, peripheral neuropathy and constipation, are totally classic for Vincristine. But beyond just managing those side effects, there is one absolute life or death safety rule for administering this specific drug. Do you know what it is?
This is what we call a never event. It should never, ever happen. Vincristine is for IV use only. If it is ever accidentally given intrathecally, that means into the spinal fluid, it is fatal. This warning is paramount, and it's a stark reminder of why we check, double-check, and triple-check our medication routes, especially with high-alert drugs like this.
And that actually leads us perfectly into our final round, critical safety alerts. Think of these as the hard stops, the absolute, undeniable rules in pharmacology that you can just never, ever forget.
Here's the first one, and it's a big one: potassium chloride, or KCl. You will see this written in all caps, bolded with exclamation points for a very good reason. Giving potassium as a direct IV push can cause an immediate, fatal cardiac arrhythmia. It must always be diluted, and it must always be infused slowly on a pump. There's 0 exceptions to this rule.
Now let's talk about a couple of critical black box warnings. First, Epoetin Alfa. It's used to stimulate red blood cell production. But here's the tricky part. If you push the hemoglobin above 11, it can paradoxically increase the risk of a heart attack or stroke. More is not better here. Second, Azathioprine, an immunosuppressant. Its major risk is severe bone marrow suppression. As the nurse, you have to be watching those blood counts like a hawk and be ready to hold that drug if their white cells or platelets start to plummet.
Whew, we have covered a lot of ground really fast, right? From drug classes to clinical scenarios and those huge safety alerts. So when you boil it all down, what's the single most important thing to take away from all of this?
The big idea here is that pharmacology isn't just about memorizing facts for a test. It's about critical thinking and application to keep our patients safe. So I'm going to leave you with this question to think about. After going through this quiz, what is one drug or one drug class that you're going to go back and review just to make sure your knowledge is rock solid? Because that commitment to always learning, always getting better, that's what makes a great nurse.